Now, can I call on Dr. Nora Fullington, Assistant Professor of Surgery, University of Massachusetts, Rochester. He's going to give a talk on Team Broken Earth, experience of a new global surgery effort.
You guys say Worcester? Is that
Worcester,
Worcester?
not Worcester.
Worcester.
All right, so I get his time, right?
Yeah.
Okay, perfect.
Okay.
So we have 30 years, 20 years, 10 years, and now you get to hear 6 months of humanitarian surgery experience. But I am the freshest view at doing this for the first time, so hopefully I can give you guys some tools for the people out here who haven't done this before but are interested in trying in the future. So we sort of fell into a very nice little situation with Team Broken Earth, and I'll tell you a little bit about that project. But it may answer a lot of the questions we have about how we can come up with a model for making this work in the future. But also I'm going to tell you about our trip and our experience and hopefully give you tips and some benefit from our mistakes or lessons that we learned. So we first became involved with Team Broken Earth when Dr. Andrew Fury came to talk at our institution at UMass. And he basically told us about his program. So Team Broken Earth is a Canadian consortium. We're not Canadian, obviously, but they're very interested in gaining more partners, and we were able to join up with them. But basically, this group has primarily gone to Haiti, has gone to a few other countries as well, but has gone to Haiti more than any of those. And they first went there after the earthquake in 2010. So it's a highly populated country and the poorest country in the Americas. So it's a little bit closer than sub-Saharan Africa, and fortunately that provides opportunity for all of us. So the average Haitian lives on $2 a day, and 75% of the people there don't have running water in their homes. Life expectancy is significantly reduced. And in terms of healthcare expenditure, the total expenditure per year per person is $71 versus the US, which is $8,362. So they found Bernard Mev's Hospital, which is basically the main hospital in Port-au-Prince, their capital city. It is the only location that has ventilators. It has an ICU. It has a pediatric ICU as well. And they receive referrals from really all across the country. So their model is a full self-contained university team. So they've been mostly orthopedic. They'll bring down surgeons, anesthesiologists, residents, nursing, any kind of staff that needs to go into these type of projects. And they'll go for just 1 week, which is much more functional for all of us. They provide not just clinical care, but also education, which you'll see as you start out, it's a lot easier to start with the clinical care than the education. And they are able to do this not just with their group, but with several groups across Canada. So there's a lot of handoff and continuity of care as well. So talking about our trip and how we got started. There are several things you need to do. I came up with like a million questions you could ask when you're starting these things, and then my timing was like 40 minutes, so you guys wouldn't like that. But so I'm just gonna kind of run through it, and I have lots of tools. If you guys want it afterwards, I'll give you my email address. So getting support. Of course, altruism is our motivator here, but we're dealing with institutions that have bottom lines. So faculty development is one major benefit of doing this that institutions appreciate. Team building, promotion of the brand, promotion of the residency program too. A lot of candidates are looking for this kind of project in their resident training programs, and it makes them want to go to your institution. And also, of course, education overall is enhanced. So we went on a scouting trip first, and I highly recommend this. First of all, I highly recommend going where people have gone before and there's already a structure. But if you can go on a scouting trip, it helps a lot. So doing that, you want to think about where you're going, hopefully a place where there already is an existing structure. You want to bring the people that are going to go with you, ultimately, a small group of them. So surgeons, anesthesiologists, we didn't bring nursing. It would have been good to bring nursing. And then you find out all sorts of information about travel logistics, room and board, what team you need, the schedule day to day while you're there, so the supplies you need, the medications you need, and also what you can expect in terms of cases and what you need to do in advance to draw those patients in. Excuse me. So this was our trip, September of 2017. This is the cheat sheet that I'll send whoever wants to see it. But these are all the questions we asked, millions of questions. And it was such an important part of the planning process to ask all of these questions. So if you want them, I'll give them to you. But we basically arrived in and met the Newfoundland team there at the airport. And we then just followed them step by step through their entire experience, at least for the first few days of it. So how they got from the airplane to the actual ground transportation, each one of those little things, you don't even think about the details that have to go into that. So we did kind of just pay attention to everything. This is us in our ground transportation to the hospital. This is Bernard Mev's hospital, which would be not only where we would work, but also where we would stay. And then there was an arrival and onboarding process where, again, we're just observing, listening to their entire experience, how it's gonna go. And then we began the question asking process that went on and on. We were able to talk to not just like the CNO, the CMO in that hospital, but also the actual OR staff to find out how things go. We learned the lay of the land, got to see where we would see patients prior to surgery, as well as the ORs and the PACU. We got to see the supplies, and as you can see, they're not plentiful and not necessarily reliable either. We got to see how Team Broken Earth brings their supplies, organizes their supplies, inventories their supplies, and uses them. And then we got to see the anesthesia equipment, which was hugely important for the anesthesia team. They know the questions to ask. That's why we were so happy that they were able to go down there with us in terms of like what circuits you need to bring, whether or not you need to bring them at all. And we also saw the inpatient facilities, which for this hospital and this location were fantastic, but in terms of what we're used to, not ideal. So in terms of our first trip, looking at this, we kind of determined that the safest thing to do, the best thing to do, would be mostly outpatient operations, at least to start. And then we can kind of work the system, figure out how to go from there, and do more complex things later. We learned about the accommodation, so what the, like where we would be staying, what those places would be like. Would there be air conditioning? Would there be running water? Would there be clean water? And we learned that we would eat there for part of the meals and go out for the rest, so we needed to learn about safe transportation. All of these things would be questions if you think about when you go back, your institution wants to know these things, to know that it's safe to send people. So that was our little back of a pickup truck transportation. And then the next question we had was, well, how do we finance this? What do we do? So they had websites, and they could create team websites where you could actually develop your own little team site and put it up on your social media and get people to donate to you. And then you could use those funds to pay for your trip. So we found out how much it would cost, how much each team member needed to raise, and then we figured out how we could utilize those funds to actually support our trip. So this is us, bright-eyed and bushy-tailed, ready to go back, almost. We needed a little assistance on the way, but we ended up in Boston, and Team Broken Earth was born. UMass, that is. So we fit into the schedule in March, and that was in between Team Halifax and Team Barrie. So we had a few-week little layover that surgeons would be coming back and could take care of our patients. But you can see also through that, there are a lot, they're just repeated teams coming. So it does sort of answer the question about a little bit of continuity of care and not going in for a week and then just being gone. So this is our timeline. 6 months started with the scouting trip. Then the next month was gaining institutional approval. Then team paperwork, clinic trips, all that, picking the team. Fundraising and then supply gathering continued from there once we had a team to actually do that. So selecting the team, I think, is a very important step. It shapes the entire experience. You need to know who you actually have to bring, but also you want to choose people who want to be there, who are motivated, who are flexible, and you want to have enough people where you can support breaks and time out and keep it safe for everybody. Residency considerations, at least for the American Board of Surgery, in order to call it a rotation, it has to be 4 weeks, and there has to be some sort of adjunct faculty there. So that's very hard to do for a lot of us. So in our case, we kind of settled with 1 week. It's not going to be a rotation. You're not going to be able to log your cases, but we have 3 weeks of vacation for our residents, so they have an extra week that they could use, so that we don't make them use their vacation time. They just get that extra week to use. There still are requirements for supervision, goals and objectives that need to be written up and then maintained while they're there, and also hours restrictions. So this one's important because this one took a lot of my time in terms of figuring out what to do. I didn't know what forms needed to be filled out, what agreements needed to be made between institution and group, Team Broken Earth and UMass. So kind of made this little list up as a general overview, but your home institution has to approve this and has to approve the individual members. So there's a form at your institution. There's somebody at your institution that supervises this and would need to give you that form to fill out and complete. You just have to find it. That's the hard part. You also need an agreement between your own graduate medical education group and the visited institution, or in our case, it was Team Broken Earth. They kind of were a proxy for that visited institution. But if you're going to bring residents, that agreement needs to be made too. Then you have to also get individual approval for each resident, and also everybody on the team has to complete then the visiting institution paperwork. And then there's health clinic requirements that need to be fulfilled. There's all sorts of vaccinations that need to occur. And also you have to make sure that everybody has insurance, evacuation insurance, wherever you are. So fundraising, I mentioned some of this already, but finding out what the cost is per person and then what you can do to try to raise that money. For us, we were a small group, so we really just had to focus on small numbers. So we were able to do it individually, and we chose team members that we thought would be able to fundraise. So we used some institutional funds to support our residents and our medical student, but otherwise the nursing staff and all the doctors sort of raised the money on their own. And tax exemption status in that setting is really important too. So supply gathering was very hard and very time consuming. Institutional donations were huge. Donation websites like these are helpful, but what they have is limited. And then you have to pay for shipping as well. And then finally, the most important thing was re-sterilization, which I had never heard of actually before this. But there's so much waste in all of our cases at home, and if those supplies are just set aside and somebody has an interest in this who knows how to sterilize, then you can re-sterilize so much and reuse it in these projects. So our trip was March 3rd. We had a great time. This was us kind of following through on all the information we had gathered on that scouting trip, followed all the steps that we had gained information about. This was our first day, our clinic day, and we were working with the staff on the ground. We got to work with interpreters that were provided there. It was kind of a really nice working situation to get out of your norm. Some of the PACU and OR nurses were there in the clinic with us, kind of fulfilling a different role and seeing patients pre-op, which was great. And then the residents got to run this clinic too, so that was huge for them. They were making the calls, making the decisions, and feeling ownership. This was us just about to start, so we have our anesthesia team there on the left and Dr. Litwin acting as maintenance staff. And then working with interpreters, and the head of the OR there kind of stretches your norm, I guess, just in terms of what you're used to in your own hospital. Now you're in a totally different situation with other people in charge, and you kind of finagle that system, and that's a learning process too. And here's Dr. Kelly in the back getting ready to operate on our first case. And ultimately we did 27 operations. We set out planning for 60. So if we were going to be disappointed, that could be a disappointing number, but this was our first trip. We advertised only for hernias. We got more than that. We did hernias, hydroceles, complex abdominal wall hernias, incarcerated hernia, and one patient who came in who ended up having dead bowel and fortuitously came when we were there. And we did pediatric circumcisions too. So we really, despite not hitting 60, we felt pretty good. We didn't have to turn anybody away, and we felt like we got the job done. The residents had a great time, did a ton of cases, got really comfortable with those cases. They also had an opportunity to switch roles, so our senior resident became the attending, the junior resident became the senior resident, so it was great for them, of course with supervision. And we worked with the staff there, with the residents and the scrub techs there from that country. We also hit pitfalls, so we learned about bottlenecks. If we only have 4 PACU beds, and those are pre-op and post-op, there's only so many patients you can move through the system, so those little things are important to know in terms of our future planning. And we learned about issues just with supplies. We didn't really have lights in the PACU, so we couldn't put IVs in. So we found a headlamp and worked with it, but it's those little lessons learned that kind of will make for more productive future projects. So another thing that we did was we had 1 day off right in the middle of our trip. And we all felt sort of bad about that initially, like we're going down there to operate, we should be operating the whole time. But it did 2 things. First of all, it gave the staff at that hospital a chance to do their work, which was good. But it also was very important for the team. I found that I go down there and I think, you know, I'm gonna get down there and I'll be supercharged because I'll be so excited we're finally going. But I think it's such emotionally challenging and hard work that you need that time off. So that team day was huge for everybody. And also, it also allowed us to go out into the community and see the context that we're working in. So we got to see some of the devastation from the earthquake. We got to see people living their lives in Haiti. And we also got to, on the lower left there, see their national museum, so some of the things that they're very proud of. At the second half of the day, we also had fun. So that's an important part of all of this too. It is a really big team building experience, and that helps recharge the batteries as well. And so lastly, just some of the lessons we learned. An existing structure is so key. It's the foundation to move forward, I think. And Andrew Fury was so instrumental in our project by giving us, you know, so much of this. Even with that, there were so many questions, so many things you had to learn, so much you had to do, that I can't imagine starting from scratch. And so many of you have done it, but I think it's so hard. So I think the key is not reinventing the wheel and using the tools that have already been developed. Another thing is have someone in customs. That's a tough one. We almost had all of our sterile packs opened until we found our liaison. Almost had an international incident. So that was huge. You have to have somebody there because you don't speak the language in many circumstances, and they don't know you, and they don't trust you. So there's that. Bringing redundant staff is very important. For our trip, you'll see down there I said go small, right? So for the first trip, I think it makes sense. Just bring bare bones. Don't aim for the stars, try to do 100 cases. Just bring what you need and then figure it out from there. But that said, it is hard when you're down there because if you don't have people to back up the people that are there, even something as simple that you never had to think about before, like when is the PACU nurse gonna get lunch, becomes an issue, right? So having a redundant number, having extra is gonna help. One thing that we learned was while we thought, okay, we're gonna bring all the supplies, but they have instruments, just beware that the instruments that don't actually work at all. So I think kind of, again, going small, keeping your caseload sort of basic is a good idea to start. As I said, the team day is important. And I think, as was echoed by several people, education really is the long game here. I think there is a sentiment when you leave these places of it's mixed emotions. You did good, but some part of you kind of feels bad too, right? You're leaving it behind. And I think that ultimately the way to really leave a lasting benefit with these people is to educate them and let them be the ones to take care of their patients better than even they do now. And then I think the overarching lesson I'm learning is it's okay not to nail it on the first time. You know, I think it's all right to, as I said, go small, to have small victories. And really, it's not an instant gratification thing. It's a next time it's gonna be a little bit better, and I'm gonna think of all the things that I wanna do better for the next time. It's just building, building, building. So that was our crew. And thank you very much. That's my email address if anybody needs any of these little tools that I made.
Thank you very much, Dr. Fullington.
Thank you very much. I like the title of your talk,
Thank you.
Team Broken Earth.
Yes.
And I should say that we are speaking in a philosophical way about humanitarian surgery. In my impression, humanitarian surgery is not to add to the people that have all the activities, from the transplantation to the so-and-so and even the robot, while other people in some other places don't have the minimal basic surgical needs. And in my impression, when we speak about humanitarian surgery, in my impression, is rather a dream than a reality. While speaking about a fake. Thank you.
And actually, did you know Haiti is the poorest country in the Western Hemisphere? That was a recent Jeopardy answer.
There you go.
Yeah.
Thank
Nora, nice job. Quick question for you. Mayor Narayan from Cornell. You know, do we have time for one question or no?
Like, can we have one
Okay.
presentation to go, and then we're gonna have some
Yes.
time for
Sure,
questions for
sounds good,
everybody.
sounds good.
Thank you.